want to welcome everyone to this afternoon's Smart Tots panel on anesthetic neurotoxicity. And I have no disclosures. Our panelists this afternoon will be Dr. Andreas Lupke from Cincinnati Children, who's going to talk to us about use in preclinical studies to guide research in humans, followed by Dr. David Bellinger from Harvard and Boston Children's, who will speak to us on important considerations in neurodevelopmental outcome studies. And last but not least, Dr. Richard Levy from DC Children's on translational approaches to treat anesthetic neurotoxicity. I just want to give you a brief introduction in terms of what exactly is Smart Tots. Smart Tots is a public-private partnership that's formed between IARS and the FDA with the explicit purpose of funding research that is targeted to make surgery safer for the millions of infants and children who undergo anesthesia and sedation every year. And 2 years ago, Smart Tots issued a consensus statement regarding the use of anesthetics and sedatives in children that is being endorsed by a number of different organizations, including IARS, the FDA, SNAC, SPA, ASA, American Academy of Pediatrics, and the European Society of Anesthesiology. And I think that this is the most current one, and it's being looked at to get updated, possibly in the next months. So to introduce this topic of anesthetic neurotoxicity, I have one slide which summarizes the essence of the preclinical studies. The models that have been used for preclinical studies include rodents and non-human primates. And the agents that have been looked at range from ketamine to inhalational volatile anesthetics and intravenous anesthetics such as propofol. All of these have actions of being either GABA agonist or NMDA antagonist. At the cellular level, they've been shown to have effects to induce neuroapoptosis, neurodegeneration, impairment of neurogenesis, growth cone polarization, dendritic density changes, and alterations in cytoarchitecture. And more importantly, in both humans and rodents, these changes have also been associated with functional outcome changes, including deficits in learning, spatial memory, motor activity, attention, social behavior. And the challenge is, what does this mean in humans? And the summary, this slide summarizes the clinical studies that have been published to date. And as you can see, there are two columns, and there are studies that have shown an association of an increased risk of anesthesia exposure with neurocognitive outcome, and a probably equal number of studies that have shown there is no increase in risk in terms of the association between exposure and later neurodevelopmental outcome. And if one were to look at the different means to develop a study, this is a epidemiologic course slide in terms of the different types of study designs. And of the studies that we have to date, the great majority of the studies, the clinical studies, are retrospective cohort studies. There are 4 ongoing studies, and one of them is the GAS study, which is a randomized controlled trial, which is perhaps the gold standard in terms of inferring causal inference, drawing causal inference. And there are also 3 other ambidirectional cohort studies that are ongoing studies for which the data are still not yet available. So in terms of looking at these clinical studies, I think the 2 variables are really important. That is exposure and outcomes. As far as exposure is concerned, whether it's single or multiple, what is the vulnerable age of exposure, whether there is any difference in terms of the type of surgery, and outcomes of the reported studies, number of different outcomes have been used. For example, standardized academic achievement test, clinical diagnosis or use of ICD-9 codes, or results of direct neuropsychological testing. And if we were to use this criteria, you can see that it doesn't really give us any clearer answer because even with a single exposure, studies have shown increased risk in terms of association, but there are also many studies that have shown no increased risk. In terms of age of exposure, again, there are studies on both sides of the column. What about outcomes? Dr. Ng used the RAIN cohort, actually was able to compare these three major different outcome measures and found that differences between exposed and unexposed children were more likely to be found when the outcome was directly assessed, neurocognitive testing, or clinical diagnosis, whether it's direct clinical diagnosis or ICD-9 coded diagnosis. When the academic achievement test scores were used, that actually there was no difference between exposed and unexposed. And using the same paradigm, we can see that the only study that has shown an increased risk of association was a study by Block et al. From Iowa, and almost all of the other studies have shown no increased risk when the academic achievement test score was used as the outcome measure. And you are more likely to see a difference when you're using the ICD-9 coded diagnosis, and the increased risk that's been shown has only been actually reported in the RAIN study. The other studies were not specifically looking at anesthesia exposure, but were secondary analysis of existing data. So where we stand today is that we have a large number of laboratory studies which I think are pretty robust to suggest that exposure of the developing brain does induce cellular effects that are neurotoxic, and most of those are associated with functional deficits. We have far fewer studies, both discrete clinical studies or population studies. And certainly we have no study in humans to look at whether or not intervention can modulate any of the findings. So today, what we're going to start with is to hear from Dr. Lupke on using preclinical studies to guide research in humans, and then we'll hear from Dr. Bellinger about some of the outcome, the important elements in terms of performing outcome studies, and then Dr. Levy will speak to us about translational approaches in terms of mitigating some of the potential neurotoxic effect of anesthesia exposure. So, Dr. Lupke.